Hello, and welcome to the IB Digest podcast from Takeda. I'm Will Mountford, and this is our second part of an interview with Dr. Ahmed Sultan about the use of histologic remission for ulcerative colitis. If a patient were to come to you or to one of your colleagues and say, I've done some reading, I've heard about histologic remission, I want that, I think that's what is going to, in my mind, in my body, feel like I am cured, I am safe, my life is better if I get histologic remission. How do I get there? What would your response be to them?
First of all, the key to success of treatment is an early diagnosis. So if you have the symptoms early, you need to be properly investigated and don't neglect your symptoms. Second, once you have an early diagnosis, you need to initiate the proper early treatment as well. The proper early treatment should actually, once you have an early diagnosis, you need to start the proper treatment for your case. And this is by assessing your disease severity. Like we said before, if you are young in age, have extensive disease, your CRP is high, you require systemic steroid at the start of the treatment, you are likely to need a higher and a more advanced medication than the conventional therapy. And here come the role of the biological agents or even the newer small molecules or the JAK inhibitors. Once you have an early diagnosis and you initiate the proper therapy, the third part is to have a good adherence to your medications. You need not to skip any dosage. You need to do the proper follow-up with your physicians. You need to repeat your lab test on a regular basis, assess your symptoms clinically on a regular basis, and you also need to repeat the colonoscopy on the proper time as advised by your physicians according to your case. And ulcer supplies will usually repeat within 6 months to assess the medication's efficiency.
Okay, well, hello everyone, and welcome again to another year of IBD Grand Rounds from IBD Academy. It's a pleasure to have you all here. It's nearly 2 years ago that we started this whole initiative. Initially, we did two very productive and really excellent years with Cleveland Clinic in Ohio, with Florian Reeder and Benjamin Cohen. And this year, we are really fortunate to partner with the Leuven IBD group. And I thank all of them, and especially Mark Ferranti, for facilitating this. It's really a great pleasure. This is the premier IBD group in the world, and they really don't need any additional introduction to all of you. I wanted to initially thank all the attendees and also all the key opinion leaders who will be joining us. And I wanted to thank, of course, our sponsors. This activity would not have been possible without our sponsors. And this activity today is sponsored by Takeda, who have been really a great partner with us and is the platinum sponsor of the IBD Grand Round series. So today, our inaugural 2025 Grand Rounds will feature two cases. One of the cases will be presented from our center by our second-year fellow, Dr. Nada Hamiyi. And the second presentation will come from Riyadh from Dr. Badr Al-Bawad. So we'd like to have everybody involved, the speakers, the experts, the moderators, and also if you have questions, please send them on the chat, and the moderators will do their best to try to address them. So without further ado, I'll turn it over to Bram to kick off the first meeting of the year.
Well, thank you, Professor Sarara, for the very kind introduction and for the invitation. It's really a pleasure to join you all as an IBD Leuven team. So today I'm joined by my colleague and our colorectal surgeon, Professor André Dore. And in the coming year, you will meet all of us, our other colorectal surgeons and my GI colleagues as well. So today we will indeed kick off, and it's my great pleasure to give the word to Dr. Nala Hamie, and she is, as already said, she's working together with Professor Sharara at the American University of Beirut Medical Center in Lebanon. So please, Dr. Hamie, the floor is yours.
So good evening, everyone. I would like to thank Dr. Sharara for this opportunity, and it's my pleasure to be presenting today's case, Crohn's disease, the ulcer that wasn't. So our patient is a 53 years old male patient with history of Crohn's disease, A3, L1 plus L4, B2, diagnosed in 2010. Our patient had a terminal ileal and upper duodenal involvement. He was maintained on adalimumab for the past 10 years. He follows up in Sweden, and he was in a clinical and biochemical remission. He underwent multiple duodenal dilatations. The last one was more than 7 years ago. He had no follow-up endoscopy or imaging for many years. He self-reduced the adalimumab dose to once monthly over the past 4 years. His last labs were in 2024 with a mildly abnormal CRP and fecal calprotectin. Back then, he was advised to do an endoscopy. However, he did not follow up. So the patient presented to our clinics in November 2024 with a few days history of melena and self-limited diarrhea and a hemoglobin of 8.8. So he was started on PPI, and EGD was performed the next day, revealing scarring in the duodenum and a 7 to 8 millimeter duodenal bulb ulcer with a very faint flat pigmented spot and no evidence of active bleeding, Forest type 2C or 3. So he was sent home on double dose PPI. The next day, the patient presented to the ED with melena, presyncope, and further drop in hemoglobin 4.4. So what's next? Would you proceed with a repeat EGD, CT angiography, balloon enteroscopy, video capsule endoscopy, or MRA? So what do you think you can do next?
We really would like to make this as interactive as possible. So please, if you have any questions, do put them forward in the chat. And also all members of the board who are joining us today can definitely also comment on their take on this case and the question from Dr. Hamie.
Can I just ask you, where was the Crohn's disease in the duodenum? Was that at the site where you just saw like a healed ulcer now, or was it on another place?
It was in a different site.
It did involve the initial images that Nada showed had this pre-pyloric ulcerations. So initially and he had duodenal ulcerations involving the bulb and the second portion of the duodenum. But these apparently scarred well. If you could see on the next slide, you could see that the bulb image, Nada, if you could advance, you could see here that this is the scarring in the bulb.
Yeah.
That's pretty well healed, and there was only this what looked like your conventional peptic ulcer in this this area. Everything else was completely healed.
Could you easily pause, because especially on the left image it looks a bit like narrowed?
Yeah, no, you could pass. I mean, it just needed a little bit of a maneuvering, so there was some scarring, but you could pass the scope directly into the distal duodenum.
And further endoscopy in duodenum 2 and 3 was completely normal.
Yes.
Okay.
Yes.
So if I may just add, thank you, Nada, thank you, Dr. Sharara, and our colleagues. Now the questions here: is it a simple ulcer or this is a Crohn related? Is that what we are getting into?
Yeah.
So did he bled or there's no bleeding? I mean, Forest 3 is there's no bleeding, usually clean base. So before just your slide, why we are asking the question? I'm sorry, I missed it. Did he bled? Did he?
Yes.
He had a hemoglobin of 4.4.
4.4. Okay,
He
so
came
usually
the
what
next
we
day
do.
to the ER with this big drop in melena and presyncope.
Yeah, so basically active resuscitation, usually that's what ABC play a major role at the beginning. And I would take a look again and see whether anything can be done endoscopically before we move to any radiological or any other means of treatment.
There is a question from Dr. Pawardi.
Yeah, I was just gonna, looking at that clinical presentation, it seems to be a little out of proportion, that small ulcer with that huge drop in hemoglobin and melena, particularly in patients with upper GI Crohn's. Proximal small bowel involvement is quite common in these patients. So, I'm hypothesizing that you might have multiple small bowel lesions that could also be potentially responsible for the anemia. And in these patients, I usually try to do an enterography first, just to ensure they don't have any strictures, fistulas, and also if they denote significant small bowel inflammation. And if that comes back negative, I still pursue a video capsule endoscopy as long as there's no strictures. And if you do have access to a dummy capsule, I would also utilize that.
I would fully agree that indeed you need further mapping of the Crohn's, but of course at the acute setting, you won't have access to the MR enterography and the additional imaging. So maybe we can discuss further what happened with this patient, Dr. Hamia.
Okay. So a same-day push enteroscopy was done, revealing the previously noted clean-based duodenal bulb ulcer without any evidence of bleeding. So the patient was given preparation and colonoscopy was performed the next day, revealing transported melena throughout the colon with no focus of bleeding and normal distal terminal ileum. So the next step was to proceed with MRE. The MRE revealed severe mural thickening, inner wall hyperenhancement, submucosal edema, and serosal hyperenhancement of the terminal ileum, reaching the IC valve, extending over 9 cm in length, 1 cm from the IC valve, with an intersphincteric perianal fistula. So the next step was to proceed with a video capsule endoscopy, which revealed a deep ileal ulcer with no other small bowel endoscopic signs of IBD activity and no luminal stigmata of active bleed. So our topic for today is going to be hemorrhagic Crohn's. And when we say hemorrhagic Crohn's, we are talking about significant rectal bleeding that usually causes hemodynamic instability and a drop in hemoglobin that often requires transfusion.
Could I just before we go on to the theory, I have one more question on what you just presented. So you very nicely showed the sequential investigations you did, but I would assume in the acute setting you don't immediately have access to MR enterography, or do you have quite rapidly?
Yes, we had access after 2 days to MR enterography.
That's amazing. Unfortunately, we don't have at all. So we have a waiting list of a few weeks in the best scenario, let's say. But I think the approach you took with, first of all, going back endoscopically and with the pediatric scope, you can ideally go a bit further into the duodenum, is, I think, definitely something not only diagnostically, but also therapeutically. So was there anything to be done during that relook endoscopy where you could stop the bleed, or was there no need to do so?
There were no signs of active bleeding, so no intervention was done.
Okay.
So there was only that, clean-based peptic type ulcer in the duodenum and nothing else really. And interestingly, also the terminal ileum, at least the image that was taken, I think they probably, this happened over a weekend. So I think they intubated the terminal ileum for a few centimeters only.
Centimeters, yeah.
And that looked normal, although the MRE suggests otherwise. But that's not unusual, I think, sometimes to have, the mucosa looks okay, and then deeper into the ileum, then you find some more disease.
Yeah, absolutely. Dr. Badr?
Yeah, I was just going to say, for this patient with long-standing disease and a significant change in clinical status, particularly anemia, we also have to keep a differential of small bowel adenocarcinoma. So this is a patient that, if I do have access to deep enteroscopy, I might want to actually get some biopsies to make sure that we're not dealing with that.
Yeah, I think that's a good point, Better. I think this patient just happens to have an hemorrhage, really. I don't think his anemia has been chronic. He's been, completely well. Now, he doesn't come to the follow-up and gets his follow-up in Sweden, but he's totally normal hemoglobin hematocrit a few months ago, before that. So this was kind of a sort of a hemorrhagic presentation that is pretty acute. And which is really the defining interest in this particular case, I think.
Yeah.
Yeah. So if I may add one thing, please. Usually when we do an upper endoscopy and there's no reason or no source of bleeding, and the patient has that severe instability, after we resuscitate, usually we send them to angio. Angio play a role also here in localizing the bleeding just before we do the MRE and other investigation.
I think presumably that would be our approach, at least in the setting where we practice, that indeed, especially if there is like a significant bleed and we don't find anything, we first usually go to CT angiography. And if we then see the blush there, we take them right into the interventional radiology lab.
Yeah, I think that's a good point. I think Neda is going to cover that CT angio is not particularly that useful in this patient population. Now, clearly, it's useful when you catch it in the act.
Yeah.
But whenever it stops, which usually is the case, then you basically don't get much.
Absolutely. Then it's low flow and then it's over. Absolutely.
So I think Neda is going to present one slide and second, and then probably kick it over to Professor Andre for maybe some input regarding why does this happen, what's his experience in terms of this happening as well. So Neda, up to you.
Okay. So as a background, hemorrhagic Crohn's, also known as bleeding Crohn, is a rare but potentially life-threatening complication of Crohn's disease, occurring in 0.9 to 6% of the cases. And of these, 15.7% to 34.7% experience it as the initial manifestation of Crohn's. The time frame between Crohn's diagnosis and the onset of bleeding shows considerable variation, ranging from 0 to 28 years. It is a distinct entity and poses significant diagnostic and therapeutic challenges because most of the time we are unable to locate the bleeding origin. So the first case of hemorrhage due to Crohn's disease was reported in 1941 by Fallis et al. And since then, multiple case reports and case series of severe bleeding in Crohn's have been published. And here I would like to open a parenthesis and discuss an important topic. So it's well known that patients with peptic ulcer often present with complications such as hemorrhage and perforation. So why do patients with Crohn's disease do not often present with these complications despite having extensive and deep ulcers? So here we would like to have the input of Dr. Andre.
Thank you very much. So I just need to say that this entity is rather very seldom. And it just happened that we had a patient with a young guy with quite extensive small bowel disease. And so he underwent like a long strictureplasty. He was doing very fine. And 7 years down the road, he came in with extremely severe bleeding. And it came from the strictureplasty zone. And there was some inflammation, but not that extensive. And so due to the fact that he was unstable, we took it out and we made a joint. We made an isoperistaltic anastomosis. Again, the patient was doing very fine, had mild recurrence, And now, 4 years down the road, he 2 weeks again, last 2 weeks, he came in with a sudden, very deep anemia. And he had a hemoglobin of 4. So, and the only place we could focus on was that small zone of recurrent Crohn's disease, but without any extensive deep ulcerations. And the thing was, what we did is again resect it and again give him a joint. So I think in those, not always you have very extensive and deep ulcerations in those patients. It certainly can happen, I guess, that you got a vessel that opens up and that starts immensely to bleed. And the same is true for a free perforation. You hardly see it, and suddenly you see one patient with a free perforating Crohn's disease, which also is extremely seldom. And I guess probably why it's seldom is that due to the chronic inflammation and probably due to the fact that you got that creeping fat that alters completely the structure of the bowel wall, that we don't see that massive bleedings. And when you cut through the zones of Crohn's disease, when you see bleeding, it's always superficial on the mucosal side. When we cut through the wall itself, it hardly bleeds. And that fatty tissue and fibrotic tissue infiltrates it and makes it rather rigid. When you normally cut through a normal bowel, all those layers starts to bleed, and that you don't see in chronic Crohn's disease. Probably that's one of the reasons.
No, this is a beautiful summary, because it really is exactly, what has happened and how we think this happened. And Nada can, discuss this a bit further, but your experience is perfectly spot on with what really happens. Yeah. Nada, go ahead.
Yeah, thank you, Dr. Andre. So as you mentioned, one hypothesis is that the chronic inflammation in Crohn's is chronic, gradual, and indolent, and this might lead to thrombosis, fibrosis, and fat creeping, which might explain that these patients less commonly present with complications such as bleeding or perforation. So in talking about perforation, free perforation is rare, but it's the most severe and debilitating complication of Crohn's, and it usually requires emergency surgery. A higher incidence of free perforation has been reported in Japan and Korea, 6.5 to 6.8% compared with Western countries, and it's the presenting sign of Crohn's in half such patients in Korea. So back to our topic. What's the most common location for bleeding in Crohn? So this table summarizes multiple case series about patients who presented with bleeding in Crohn. So it's interesting to note that the average success rate for determining the bleeding location stands at 33.4%. And the majority of bleeding originates from the ileum and colon, with an ulcer eroding into a vessel being the most common source of bleeding. So what about the inflammation burden in patients who present with hemorrhagic Crohn? So although it might seem logical that these patients might have a higher inflammation burden that might explain such a presentation, two studies have focused on the inflammation burden in these patients. So the first study conducted by Kim et al. Revealed that 77.8% of these patients had a Crohn's disease activity index of less than 150, and 47.8% of the patients exhibited a normal range of CRP. The second study has also revealed that 64.7% of the patients had quiescent Crohn's disease at the time of bleeding. So most of the patients don't have active disease at the time of their presentation. So here I present an interesting study about 34 patients who presented with acute lower GI bleeding with significant findings. So the mean age of the patients was around 34 years. The duration of the disease was 5.6 years. The site and origin of bleeding was mainly colonic, as I mentioned, with ulcer being the most common cause. Most cases were diagnosed by colonoscopy, followed by angiography. The treatment was surgical in 20.5% of the patients, endoscopic in only 7 patients, and the recurrence rate was 35% within 3 years. So what about the diagnostic evaluation? So multiple modalities can be used in diagnosis, with the most having a highest yield is colonoscopy. So in 2 studies conducted by Pardee et al. And Belash et al., there was a high yield for colonoscopy reaching 78 and 60%. However, as we can check the yield for mesenteric angiography, it's about ranges with an average of 33%. So moving to the treatment of hemorrhagic Crohn, so although the ability to find a bleeding source and to directly treat is fairly limited, the good news is that usually the episodes resolve spontaneously. So the mortality rate of acute severe GI bleeding in Crohn ranges from 0 to 14.3%. And the treatment options might include embolization, surgery, endoscopy, anti-TNF alpha therapy, steroids, or other biologics. So what about medical therapy? So the efficacy of steroids in treating acute severe lower GI bleed in Crohn's is controversial, and multiple studies have revealed that it has a limited role in hemostasis. Regarding anti-TNF alpha, specifically infliximab, it has a remarkable efficacy in rapidly inducing and maintaining remission in Crohn's, with successful cessation of bleeding in at least 11 case reports at a dose of 5 mg per kg. There was a small study about thalidomide, which revealed successful cessation of severe intestinal bleeding and in patients with a steroid-resistant Crohn treated with a daily dose of 300 mg of thalidomide. So moving to the interventional therapy, so endoscopy has a limited role in the management of bleeding Crohn because, as I mentioned, most of the time you cannot find the bleeding origin, and it might not be technically feasible to have any interventional therapy. Embolization, so it has been reported that it has a high success rate and an acceptable clinical success rate in patients with positive angiographic findings. And of course, surgery is reserved for the life-threatening or refractory bleeding, with a rate ranging from 4.3 to 7.6%. So what about rebleeding? So this case series that was published in 1991, it followed 21 patients after presenting with a GI bleed related to Crohn, and the rate of bleeding was around 19%. There are limited data that suggested that the use of anti-TNF alpha therapy could reduce the risk of rebleeding in anti-TNF naive patients. So now that we have explored our topic, the real question is what is the impact of this presentation on the disease course? So do these patients have a complicated disease? Would they require escalation in the therapy and increased utilization of biologics or steroids? Do they need higher intestinal resection? So back to our patient, the bleeding stopped on itself without any further intervention. He received blood transfusion, IV iron, and he got discharged. Adalimumab treatment was optimized to every other week. He had no recurrence of bleeding at a follow-up visit 4 to 5 months later, and his latest lab were within normal limits. And he is scheduled for an assessment of the mucosal healing with an MRE and an endoscopy. Thank you.
Very interesting, and thanks a lot. I have a question linked to the angiography, and it was already touched upon, and maybe it's a question also for André from a clinical perspective. So if we would say we go for angiography and we find the culprit and we go for embolization from a surgical perspective, do you prefer this because of the ischemia? It might be quite a broad part of the bowel which we are potentially losing, no?
Yeah, but normally they can go quite deep and don't gonna obliterate or the main vessels. But I do agree that I'm not so afraid for small bowel, but rather afraid when they enter for some branches of the colon, and depending on the collateral circulation. And so we see less problems with small bowel than you see with colon. And sometimes you get necrosis of the colon, and then of course it becomes a more extensive resection. Sometimes, but here, of course, you had a clear culprit. You see that there is distal ileal disease. You know where the location of the bleeding is. In some patients where we don't see really on CT scan, you don't see at the outer side something. In those patients, we leave inside the sheet and can use the sheet then to give some diluted methylene blue during surgery, that we really can see what is the region of interest that caused the bleeding. And then you can add on that to do an enterography or an enteroscopy during surgery, where we open small bowel and then you can go inside. But sometimes it's very hard to find a bleeding location, and often it stops, and then you never can focus, you never can really touch on it. The question here is, of course, what you're gonna do with this patient, and I guess in upfront we would discuss surgery.
Yeah.
We've now quite a life-threatening complication, and we know that it's self-limiting, but it's a short form of terminal ileal disease. Patients will not lose a lot of bowel, and you can easily do an ileocecal resection and get him patient out of trouble, and then have a close follow-up. But again, when you start medical treatment, now it's going to be the task to look whether you can find mucosal healing and deep healing. If not, it's still probably going to end with localized surgery.
Actually, if I may add one point, very interesting case. We had very similar case with patient had actually mucosal healing, but he bled on the outside. Actually, he had hemoperitoneum, and he collapsed, and he was taken to the OR and had left hemicolectomy, and he had a huge hematoma in the left colon. And we still don't know what happened. So most likely that's what happened. He bled, but on the inside, not on the outside, not inside the lumen. He bled inside the peritoneum. So it's very interesting cases.
May I intervene and ask everybody a question? Philippe Sanyour from Lebanon. I've had a couple of cases in 30 years of career of one bleeding and one free perforation of Crohn's after initiation of corticosteroids. So at that time, many years ago, when we checked, we thought that maybe corticosteroids may be melting the inflammation and opening something and letting this happen. So the corollary question is, what are the risk factors and the predictive factors for such rare events, and can we prevent it? And if corticosteroid is really a culprit in this?
Yeah, I mean, if I may, Philippe, I can just answer, because I looked at this more recently, and maybe I have a bit of recollection of what this, but you're right. I mean, I've had 3 hemorrhagic Crohn's and 1 spontaneous perforation in my career, these patients. So very rare. And the spontaneous perforation was actually the initial presentation of that patient. The Korean data that looked at the perforation, at least, which had a reasonable series, because they had like a 6% incidence of this happening, they didn't really find a really good reason for why. Only stricturing disease is, as one would expect. Even the fistulizing was on the univariate analysis, but wasn't really on the multivariate analysis. They're rare, and it's hard to really come out with factors. What's striking, I think, and this case also underlines it, and as Andre mentioned, is the fact that their inflammatory burden is not necessarily high. They just somehow, one ulcer just makes it through and just causes this problem. Yeah,
I agree, and potentially in the case series out there, that might be part of a bias in those patients very sick who go on to steroids or on other advanced therapies, actually their likelihood presumably is already higher regardless of the therapy which was initiated. And that makes it even more challenging, I think, to draw conclusions given it's so rarely seen.
Yeah, you know, if I also may add, I have 3 patients who had perforation post-initiation of infliximab. And, you know, we had so many discussion. I did some review. Even if you Google, there is some Korean and Chinese actually data on perforation post infliximab. Now, they may not be related to the you know to the drug itself, but again, you know, whether the medication is doing something to the inflammation, and that's what led to the perforation. 3 cases.
Against that, it could be a corollary, as Bram mentioned, of severe disease. I think that's what happens in most of the perforated studies. Yeah.
In a few other trials, it also was, I think, in the anti-IL-6, which never made it into the market, there were also some spontaneous perforations. In the JAK trials for Crohn's, there were also some spontaneous perforations, which we don't see happening in real world. So presumably this was just bad luck with very sick patients entering the trial, and therefore potentially provoking a spontaneous perforation which was completely independent of the drug itself.
I would certainly question the patient whether there was no use of NSAIDs, because sometimes for some other reason they use that, had some shoulder pain. And we had patients with ileoanal pouches that we warned them not to use that, and they used it. We have seen free perforation of a pouch. We have seen severe bleeding in a pouch of an ulceration, just due to the fact that they used NSAIDs. And I think this is important, I guess, to mention and also to warn again the patients for that.
Yeah, absolutely. All right, great.
Thanks a lot, Dr. Hamie. Very interesting case.
Thanks.
So, and with this, we would like to move on, and it's a great pleasure to introduce Dr. Badr from Saudi Arabia. He's also a good friend, and it's great to meet here virtual, and he will speak today about acute severe ulcerative colitis or not. Badr, please, the floor is yours.
All right, thank you so much. All right. Thank you, Bram, for that kind introduction. Always great to see everyone on this excellent conference. and it's really my pleasure and honor to be with you. And I have hopefully a brief case, but it also has some important, I think, learning points. I'll go ahead and get started. This is an 18-year-old gentleman with no past medical history, who initially in April of 2021 presented with 1 year of persistent watery diarrhea that progressed to bloody diarrhea. At his local hospital, he underwent a flexible sigmoidoscopy that showed inflammation that was described as Mayo UC score 3, and his pathology showed moderate chronic active inflammation without granulomas. He had a CT abdomen and pelvis with contrast that did show a short segment wall thickening of terminal ileum, but no hyperenhancement. He had the pre-biologic workup performed, but he was initially started on azathioprine, mesalamine, and prednisone. He had a repeat full colonoscopy also done locally within 6 weeks to get a full assessment of his inflammation, and it did show pancolitis with a normal terminal ileal exam. A few months later, he presented with acute pancreatitis that was thought to be secondary to azathioprine, so that was stopped. At the same time, a colonoscopy was repeated and showed improvement, but persistent inflammation with Mayo UC score 2. And his pathology report continued to show classic changes for ulcerative colitis or inflammatory bowel disease in general. So he was initiated on vedolizumab after repeat of his pre-biologic workup, and about 6 months later, he had no clinical improvement, and the frequency of vedolizumab at that point was increased to every 4 weeks. In May to June of 2023, a colonoscopy was planned, but the patient refused. And at that time, he was still symptomatic. So locally, they had repeat biologic or pre-biologic workup with a quantiferon that was negative. They did get a CT abdomen and pelvis that did show changes of mild colitis in the left colon, with engorgement of the mesentery, multiple reactive lymph nodes, and appearance consistent with what we would see sometimes with ulcerative colitis. So around June of 2023, he was switched to infliximab, and he was started on high-dose induction, considering that he had severe disease. And this was all done locally at his local hospital. He received 10 milligrams per kilograms on week 0, 2, and 6. And then he proceeded with every 6-week dosing. So he presented to us over a year ago, and his initial presentation was in January of 2024. At that point, he reported to the emergency room. He was febrile, he was quite tachycardic. He had a heart rate of 140, a very low weight. His BMI was 13. He was pale, dehydrated. He only missed 1 dose of infliximab and was only on budesonide. He was having up to 5 bloody bowel movements a day, and he reported a productive cough for the past month. So initial workup on hospitalization showed a CRP of 97. His albumin was quite low at 2.7. His hemoglobin was 6, and his calprotectin was over 1,000. He had a stool GI PCR multiplex performed, and that was negative for infection, including C. diff testing. So these are images of his initial flexible sigmoidoscopy, and these are representative images of the inflammation in the rectum. It showed patchy inflammation. And you can see some erosions in this image. And again, you see patchiness of the disease. And also in the sigmoid, there was more severe inflammation with spontaneous bleeding. And these are representative images of his abdominal and chest X-ray that you can take a look at. And then on the next slide, I have representative images of a CT chest that was performed. So in a brief summary, this is an 18-year-old man with severe pan-ulcerative colitis, despite dose-optimized infliximab of 10 milligrams per kilogram every 6 weeks. And he did miss 1 dose, and he presented systemically ill with respiratory symptoms and chest findings. So I wanted to pause here to discuss potential differential diagnosis and then your next best step to do.
Can I just ask, isn't there a discrepancy between the endoscopic findings and how bad the patient is? Wouldn't you expect Bram to have like more severe inflammation in the colon? I would say this is from an endoscopic view a rather mild colitis. I wouldn't expect the patient being as sick.
Fully agree. I think both clinically and also in terms of biochemistry. So a CRP of almost 100 is, especially for UC, very high. And then I would assume like way more deep ulcerations, denudated mucosa, and there is spontaneous bleeding, but it's not the worst colon I've ever seen. So I fully agree. Presumably, with the respiratory symptoms being systemically ill and also the radiographs we've seen of the chest, I think we should definitely consider alternatives for his inflammatory state on top of the IBD itself. So Badr, what the patient was purely on infliximab monotherapy, so he was not on concomitant immunomodulators nor any steroids at that stage?
Correct, Bram. So he was on infliximab monotherapy. If you recall, he developed pancreatitis in the past. He was on budesonide when he came to us. And I think that was prescribed to, help control some of his symptoms. And as rightfully mentioned, you saw the images. They're really out of proportion of how systemically he is ill. We look at the inflammatory markers, you look at his weight, look at even his vital signs. His heart rate was almost 140.
Yeah, if I may, better a question. I mean, frankly speaking, I don't like his CT. I'm sorry, his chest X-ray. Is that miliary something? Especially also the CT looks like more like a nodularity.
Cavitation.
And the CT also looks very bad. So what is this? Is it TB activation or something?
Well, that's in the differential, definitely. TB is in the differential, but I figured maybe we could discuss some other, potential etiologies to have in a patient with IBD who's on immunosuppression to have respiratory symptoms and potentially similar CT scan findings.
Yeah, clearly, I think an opportunistic infection is a possibility. Now, it depends on the geography where the patient is. If it's in the Midwest, think histoplasmosis. You could think of other differential. It's not your classical, PJP sort of presentation. You don't have the cavitation usually, or the severe illness. But I mean, clearly, I think TB is probably a leading diagnosis here, but one should entertain other infections, of course.
Aspergillosis.
Yeah.
I fully agree, and I think other rare entities which do not completely fit with the current status is like drug-induced interstitial lung disease, but that's not, first of all, the clinical presentation, and secondly, also not the chest X-ray usually looks completely different in these patients.
Bram, can you tell something? At the initial CT scan, there was like terminal ileitis. And then the patient started treatment and suddenly developed a full colitis. And then at each endoscopy, the terminal ileum turned normal. How?
I think it's very difficult to judge because indeed it's a reflection I had as well when I was listening to the story, is that you could say, well, this is backwash ileitis, but there was no pancolitis at the time of the first TI involvement, as far as I understood. So either there was an infection super positioning on top of the UC, or this is still Crohn's, although all the endoscopic pictures to me look way more to UC as compared to Crohn's. The other question I have for you, Badr, not really related with the respiratory symptoms, but what really struck me throughout your story was that this young man already had quite some CT scans throughout his disease journey. Could you comment on the use in Saudi Arabia or in the Middle East overall on ultrasound for monitoring? Because I think this is something we as a field all have to try to embrace to reduce the radiation risk for our patients.
Yeah, absolutely. That's a really great point, Bram, on how we kind of assess and monitor disease. I mean, if we look at Crohn's disease patients, I think at least in our region, we have long wait times. Intestinal ultrasound is utilized in some centers in our area, so that is always an option. But as you mentioned, we should really avoid using CT, particularly in this man who's quite young. And some of his CTs came across from going to emergency rooms, but some were also assessed in the outpatient setting. So definitely agree we should try to utilize more intestinal ultrasound, at least to assess the bowel and UC.
I think interestingly, while Badr is preparing, there was I don't know if you all saw yesterday, there was a JAMA article that suggested that probably 5% of the new cancers that are going to be coming up are going to be due to CT radiation.
Right.
And yeah, and it's indeed, I think, something, it's what Badr was mentioning, and I think the same we still experience. So many IBD patients going to emergency still by default get a CT scan where it's actually not needed at all. And that's what we try to repeat to our fellows as well. It's only when there is, like, of course, a suspicion, for instance, of a post-operative complication, I think there you can really justify CT, and in some really emergencies, but not the routine IBD patient visiting an A&E department, their ultrasound should really leading instead of CT scans repetitively. So I think, Badr, in terms of your question and the differential diagnosis, I think we all are more or less hinting towards an opportunistic infection with TB potentially on top of our list. Could you give us some more insights?
Yes, so I think a lot of these were already mentioned. You know, IBD pulmonary manifestations is interesting. You know, if you look at the data, it's actually one of the most common extraintestinal manifestations, particularly bronchial disease. And for this patient, the reading on the chest X-ray is a possible cavitation, and the reading on the CT chest is a clear consolidation with cavitation and bronchiectasis, multiple non-cavitating pulmonary nodules, thickening of his bronchial walls, and also multiple enlarged mediastinal and hilar lymph nodes. The constellation of the findings are quite suggestive of open or active TB. So going back to his endoscopy, the biopsies did show chronic active proctocolitis, but no CMV. There's negative AFB stain, negative MTB PCR, and we did collect cultures at this point. So he started on IV methylprednisolone, and his sputum cultures were positive for TB, and he was started on RIPE therapy. And we actually had to increase his steroids because of a paradoxical immune reconstitution-like reaction that he actually occurred with him with treatment of TB. And an interesting point to note is that rifampicin was one of his agents used in the therapy, and rifampicin increases the clearance of prednisolone by 45%. And that was also one of the reasons we had to go up on his steroids. Now, about 7 to 10 days later, the number of bowel movements remained quite a bit stable, which was 5 per day. His CRP was only 92 from 97. He was still spiking fever. He was able to tolerate an oral diet. And obviously, throughout his hospitalization, we had our colleagues in colorectal surgery following the patients. Now, what was interesting is about a week or so later, his rectal biopsies came back positive for TB. And we obtained an enterography, and the reason for that is that question of small bowel disease. And what it noted is there was disseminated abdominal tuberculosis with hepatosplenic microabscesses and also peritoneal involvement. And he had quite a bit of extensive involvement. When we look at his MRI brain, which was actually performed not for symptoms, it was mainly to make sure that he didn't have tuberculoma, which he unfortunately did have, a parenchymal focal lesions involving his cerebral hemispheres compatible with a tuberculoma. So he came to us quite sick with disseminated TB. So he's treated also on top of his RIPE therapy with antibiotics. The prolonged fever and the slow clinical response was thought to be paradoxical reaction in disseminated TB, and that's the rationale that he was kept on steroids. And we also added sulfamethoxazole trimethoprim for PJP prophylaxis. So he had quite a bit of long hospitalization, and we're up to day 35. And at that point, he is starting to improve. He gained weight. His albumin has now improved. His CRP is down. No spikes of fever, no change in his GI symptoms. And then repeat cultures have returned negative. So he was discharged on right therapy and a tapering course of prednisone. So now we're seeing him 3 months after initiation of TB therapy. He's tapered off the prednisone. No changes in his GI symptoms, mainly 5 loose bowel movements a day, but he does have urgency. At least he was not having rectal bleeding. We performed a colonoscopy, and that's mainly to assess his TB response. And it did show patchy inflammation with erosions consistent with a Mayo EC score of 2 from the rectum to the cecum. His biopsies showed chronic active inflammation, but it was negative AFB and negative culture. And these are images of his repeat colonoscopy. You can see there is still persistent moderate inflammation throughout the colon with small erosions. So I'm going to pause here for our second discussion point. And I think this is where kind of the dilemma, or, what would be your next step? The patient is on active TB therapy. He's showing clinical improvement in his status overall. His GI symptoms are rather mild to moderate. He still has urgency and up to 5 bowel movements a day. And his colonoscopy shows persistent inflammation without any evidence of persistent TB, at least on his biopsies.
So I think there are many alternatives. I think the first question which would come to my mind is, first of all, like, if we would go back completely at the start of his diagnosis, are we certain it's UC, or was it already TB mimicking the IBD? I think that's presumably the first question. And we've had a few cases in the last years, not specifically with TB, but with other opportunistic infections really mimicking IBD, where we really went back and asked for the pathology specimens from the early days at diagnosis in other hospitals, and where we could prove that it was actually from the start not a true IBD, but it was an infection already back then. So that personally would be my first step. And then, of course, if it's confirmed that this is UC with then the complication of TB under anti-TNF, then I think it's a discussion on what is the safest alternative. Would you go back to infliximab? And that's a question we sometimes get from our pneumologists. We've had 2 or 3 cases of disseminated TB in the last 2 years under infliximab, and actually for exactly the reason you mentioned, with the immune response reactivation, actually our pneumologists asked to restart infliximab to dampen the systemic inflammatory response rather than just purely for the IBD. But that's, I think, something to be discussed with your local infectiologist.
Yeah, those are really excellent thoughts. If I might just add on it, that we were thankfully able to obtain 3 sets of his biopsies, and they were reviewed by our pathologist. And they're consistent with chronic active inflammation. There were no granulomas to suggest Crohn's also, but there were no changes to suggest TB, and they did show chronic active inflammation. So that's really an important starting point. Particularly, we talk to our fellows whenever you see a patient, make sure that the initial diagnosis is confirmed.
Yeah, I think the question is certainly worthwhile. I just find it pretty unlikely that the patient would have TB involving the whole colon and not be superbly sick like he was when he presented later. The question of TB in the biopsy is similar to CMV in the biopsy in acute severe ulcerative colitis. So I really doubt that this started off as TB, but definitely finished off as TB.
So Badr, would you move now to a JAK or to an interleukin?
Right. So that's our next step. Do you want me to proceed with the slides for time's sake? Yeah. So at this point, as Ada mentioned, it seemed pretty clear that he does have ulcerative colitis, but he unfortunately had potentially acquired an infection while on infliximab therapy. So we initiated him on ustekinumab, knowing that the rate of TB reactivation with ustekinumab is quite low. He had clinical improvement. If you recall, he used to have up to 5 bowel movements a day. He was down to 2. No urgency. We saw a really nice drop in his CRP down to 6, and his Calpro dropped to 48. We're planning a repeat colonoscopy soon. He completed 1 year of anti-TB therapy at a repeat scan, which shows complete resolution of his liver lesions, peritoneal disease, and lymphadenopathy, and also significant improvement in his splenic lesions. So I thought this was a really good case in the sense that, if you recall, he was followed up really closely by his local gastroenterologist, and prior to initiating any biologic, the patient has had a chest X-ray and a quantiferon. And I think this case really highlights that we should not just rely on some of these tests, because we know the sensitivity and specificity is not perfect. Or this person could have had actually acquired the infection during infliximab therapy. So I have a few slides if you want me to go through, or if you want
Can
to
I just ask one question? How do you achieve so rapidly an improvement in his nutritional state? Because he entered with a very low BMI, and progressively, is that just by getting the infection under control, or did you give him some enteral nutrition on top of that, or what were the measures taken?
Yeah, that's a great question. So I didn't put this in the slide. Initially, we tried exclusive enteral nutrition, but the patient completely refused it and did not tolerate it and wanted to eat food as soon as he was getting that therapy. But we tried to do that to save us the need maybe to use immunosuppressive therapy, but the patient wasn't tolerant to it.
Okay.
Badr, another question I have is like, what is your approach on rescreening for TB while you have a patient under biological and especially under infliximab? Is this something you do routinely, or is this only when patients are coming really from regions where there is a very high prevalence? What would be your advice and guidance here?
Yeah, so our protocol is to do a quantiferon or an interferon gamma release assay annually on all patients on advanced therapies. Sometimes we do exclude vedolizumab, but we figured it would be easier to protocolize if we just include all advanced therapies. We are not doing necessarily a chest X-ray every year, but we're definitely doing the interferon gamma release assay annually.
Which makes complete sense. And I think even in regions like ours where TB is not very prevalent, as I said, we've had a few disseminated TBs in the last 2 years. I think with so many people traveling around the world, it's very, very difficult to avoid it. And I think the safest strategy presumably is indeed to do the annual quantiferon.
Yeah, if I may add one thing, this is very interesting, Badr, because we do see few cases of TB, but with the Crohn, not with the UC. So this is interesting, and again, whether this is an superimposed infection, but again, I haven't seen, frankly, TB with UC, but we saw it with Crohn disease.
Yeah, to your point, Dr. Zahar, that usually that's where sometimes the dilemma comes in, because Crohn's can really mimic TB, or vice versa. TB can really mimic Crohn's, and that's where we get in trouble sometimes. Would you like me to proceed with the slides?
Yeah, sure.
Yes.
Yeah.
Okay, so I just wanted to highlight for our group, so looking at the prevalence of tuberculosis in our area, and this is some recent data. If you compare the Eastern Mediterranean region to Europe, think that this is the rate of TB is about 3 times, but we're also 3 times less to where it's more prevalent in the African region. But you also have to note the slope. You can see that the slope in the African region is pretty steep, but it's not as steep in the Eastern Mediterranean region. And there's quite a bit of new cases, and particularly relapse cases, that might have been responsible for not the most steep decrease that we see in other regions. Now, to Dr. Zaha's point, the usual diagnostic dilemma is this Crohn's or intestinal tuberculosis? And there is no diagnostic test that will tell those two apart. It's, I would say, putting pieces of the puzzle together when you're looking at clinical, endoscopic, and radiologic hints that would favor Crohn's or tuberculosis. And this table is not to go over all the details, but just to look at some features that will favor Crohn's versus tuberculosis. You know, to Dr. Ala's point earlier, that if you see, usually with tuberculosis, it involves 3 or less segments, usually involves the ileocecal valve. It's usually the patulous ileocecal valve, and it's usually transverse ulcers as opposed to linear ulcers that we see with Crohn's disease from an endoscopic standpoint. From a radiologic standpoint, typically you have concentric strictures with asymmetric thickening with tuberculosis, but the most important one that would maybe distinguish it more is the central caseating lymph nodes that are seen on imaging with TB rather than Crohn's. And this is just to highlight that there's really no perfect test to tell apart intestinal TB from Crohn's disease. If you look at the sensitivity and specificity of all these tests, they're anywhere between 70% at maximum. And this includes the PCR, TB culture, and the AFB, which is quite, the return on the AFB is quite low, which is only 5%. Can we use prediction modeling and AI to help us differentiate TB from intestinal tuberculosis? And I was surprised that there's quite a bit of work in this arena of using prediction modeling and incorporating clinical, endoscopic, and radiologic parameters. The sensitivity of some of these prediction models can be anywhere between 80 to 95%. Now, one that I particularly like just because of ease of use is this model that was, I think it was the University of Michigan group, that you can scan the QR code if you're on the call, and you'll get a calculator that you'll put in different clinical, endoscopic, radiologic parameters, and it'll give you the probability whether this is intestinal tuberculosis or not. And this is, again, not a perfect test, but it still has a reasonable area under the curve of 94. So what do we do in these cases where there is a dilemma, whether this is intestinal TB or Crohn's disease? Obviously, we do a thorough history physical, endoscopy, histology, microbiology, imaging, and potentially can use prediction model. But in essence, the dilemma can persist. And what do we do when there is a persistence of dilemma between intestinal TB and Crohn's? And it is recommended really to treat this as intestinal TB for 2 to 3 months, and then to do a reassessment. So is there a clinical response or not? If there's clinical response, as within our patient, it's really important to do a colonoscopy and repeat the imaging, because as we know, this could still be Crohn's disease, for example. So you would get more biopsies, you would look at the endoscopic response compared to the baseline. And, you know, the range is anywhere between 3 to 6 months. You know, some will advocate for 3 months because you don't want to delay the diagnosis of Crohn's disease too long. Now, if there is resolution or significant improvement, then, and this is most likely intestinal TB. If there's persistent inflammation, however, this can be Crohn's disease, but also cannot, you know, we have to rule out whether this is multi-drug resistant intestinal TB. Now, if there's no response to treatment for intestinal tuberculosis, then definitely repeat colonoscopy and imaging, and if needed, a diagnostic laparoscopy. So I think this is all I had in terms of backup slides.
Beautiful, thanks a lot. I think this last slide was really brilliant to give the overview and set the scene of how to approach this challenging topic. Any other questions from those watching or from the board members joining this call as well?
Just one question, Better. What is, if you look at your repeated quantiferon, I'm just wondering, what is your pickup rate for a change? Because I suspect it's pretty low, isn't it? That people change. And then the question is, how good are those tests on the advanced therapies as well? Does it affect your gamma interferon release in any way to be on these agents? Or
right? So maybe I can take the last one first. Do medications affect the interferon gamma release assay? So the number one medication that affects it is steroids, right? So that steroids will give you indeterminate results, and also malnutrition, particularly low albumin, is associated with an indeterminate response. The drugs themselves have not been really associated with, altering the interferon gamma release assay results. Now, the pickup for me is quite surprising. We actually do pick up positives, and there's literature on this also from areas with low prevalence, such as the US, that does show that you do actually pick up these positive quantiferons on patients with being treated with advanced therapies. And I think the point that was brought up earlier, patients travel all over the world now, so they can really pick it up they could be in a low incidence area, but they went to an area of high incidence.
So new infection is what we're talking about, not really
Absolutely.
latent that has reactivated and wasn't picked up the first time around. Yeah.
Absolutely.
Gotcha. Okay. Yeah, terrific case. Yeah, thank you.
Great, thank you.
All right. Well,
Okay.
I can close. Thank you, Bram. Thank you, Andre. This was really a wonderful session. Thank you, Badr, for the presentation, and all the people who joined us for the lively discussion. Our next IBD Grand Round will be coming up in, I think, a couple of months. Nancy will share the information, and I want to thank Bram and Andre and the Leuven Group for really being with us with this initiative, and again to thank Takeda for their sponsorship today. Well, we'll be seeing you soon then, hopefully.
Thank you for having us.
Thank you.
Thank you
so much.
Thank you.
Bye-bye.
Bye.
Hello, and welcome to the IB Digest podcast from Takeda. I'm Will Mountford, and this is our second part of an interview with Dr. Ahmed Sultan about the use of histologic remission for ulcerative colitis. If a patient were to come to you or to one of your colleagues and say, I've done some reading, I've heard about histologic remission, I want that, I think that's what is going to, in my mind, in my body, feel like I am cured, I am safe, my life is better if I get histologic remission. How do I get there? What would your response be to them?
First of all, the key to success of treatment is an early diagnosis. So if you have the symptoms early, you need to be properly investigated and don't neglect your symptoms. Second, once you have an early diagnosis, you need to initiate the proper early treatment as well. The proper early treatment should actually, once you have an early diagnosis, you need to start the proper treatment for your case. And this is by assessing your disease severity. Like we said before, if you are young in age, have extensive disease, your CRP is high, you require systemic steroid at the start of the treatment, you are likely to need a higher and more advanced medication than the conventional therapy. And here come the role of the biological agents or even the newer small molecules or the JAK inhibitors. Once you have an early diagnosis and you initiate the proper therapy, the third part is to have a good adherence to your medications. You need not to skip any dosage. You need to do the proper follow-up with your physicians. You need to repeat your lab test on a regular basis, assess your symptoms clinically on a regular basis, and you also need to repeat the colonoscopy on the proper time as advised by your physicians according to your case. And ulcer supplies you usually repeat within 6 months to assess the medication's efficiency.